Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Morning, Dr. Armitage. Thanks for squeezing me in. The receptionist said your list was jam-packed.
Good morning, Mr. Diaz. I'm glad you came in. Please call me Julia. I can see you're a bit winded. Let's get you comfortable first. Would you like some water before we start?
Water would be great, thanks. My mouth's been like sandpaper lately, especially overnight.
Here you go. Take your time. And when you're ready, tell me, in your own words, what's been bothering you most.
It's the breathing, first and foremost. I've had this smoker's cough for years, but in the last month I feel like I can't get a full breath, especially when I lie down. I used to make it through the night with the oxygen, but now I wake up every hour, sometimes after only 15 minutes, gasping like someone's put a pillow over my face. I'm lucky if I scrape together 4 hours of sleep in total, and there've been nights I clocked just 1.
That sounds frightening. Is the cough different now or just more frequent?
More frequent and drier. No phlegm worth mentioning, just this raw bark that rattles my chest. My wife says she hears me wheeze from the hallway. The oxygen helps a bit, but the cannula leaves my nose crusty, even with the little bubbler we fill with distilled water. The hardware store ran out of the jugs last week, so I've been cheating with tap water. I know I shouldn't.
It's understandable. We'll talk about better solutions for the dryness. You mentioned chest discomfort on the phone as well?
Yeah, left-sided, like a dull pressure the size of a hand. It shows up when I'm just sitting watching TV, not when I'm walking, oddly enough. It lasts 5, maybe 10 minutes, and I feel short of breath until I chew an aspirin. That settles it down within half an hour. No sweating, no arm pain, nothing shooting up my jaw, but it scares me because my father died of a heart attack.
I hear the worry in your voice. We'll look into your heart thoroughly. Anything else that's been nagging you?
I get this stabby ache under my left ribs that comes and goes. Sometimes it hooks around to my flank. I've had kidney stones before, so every twinge down there sets off the alarm bells. The urologist booked me for another CT early next month, but waiting is stressful. And with the breathlessness, I keep wondering if everything's connected. Lungs, kidneys, even gallbladder maybe.
Let's walk through each system one by one so nothing gets missed. Before we do, can you tell me how all this is affecting your day-to-day life?
I'm retired, but I used to tinker in the garage restoring old radios. Lately, I last 5 minutes at the workbench before I feel winded. I nap around noon, though it's more fatigue than real sleep. My wife catches me dozing in the recliner, mouth open, because my nose is too dry to breathe through.
Thank you for that picture. I'm going to recap to be sure I've got everything straight. Worsening shortness of breath and cough, broken sleep despite nighttime oxygen, intermittent left-sided chest tightness relieved by aspirin, dry mouth and nasal dryness on oxygen, and episodic left upper quadrant pain with a history of kidney stones. Did I leave anything out?
That's the jackpot.
All right, let's look at your lungs first. I see you're on mometasone with formoterol once in the morning and ipratropium 4 times a day. You used to take tiotropium but stopped because of dry mouth, correct?
Exactly. The tiotropium felt like cotton was glued to my tongue.
Have you noticed any pattern, say missing the morning dose making the night worse?
I'm religious with the morning inhaler. My phone alarm nags me. If I forget a noon ipratropium puff, I'm wheezier by supper time, but nights are bad no matter what lately.
Your last pulmonary function test couldn't be completed. They had a machine error, so we've arranged a full repeat on the same day as your CT. That will tell us how much obstruction we're dealing with and whether the oxygen settings are appropriate.
Good. I never saw the numbers last time, just heard the technician swear at the computer.
We'll make sure the results reach you in plain language. Regarding the oxygen, what flow rate do you dial in at night?
They set it at 2 liters per minute. I've never touched it, though I wonder if I need more.
We'll capture saturation during an overnight sleep study. The previous study was cut short, so I'm ordering a redo. It will measure your oxygen levels breath by breath and pick up any apneas or hypopneas that might explain the fragmentation.
I don't think I snore, but my wife says I sometimes choke then gasp. Sounds like a horror film.
Those gasps can be mini awakenings that you don't remember. Treating any sleep apnea should lighten the load on both your lungs and heart.
Speaking of hearts, does sitting down chest pain sound like heart disease to you?
It's atypical, but we never assume. Because treadmills are hard with your breathing, I'm booking a pharmacologic nuclear stress test. No running, just medicine to mimic exertion while we image blood flow. I'd like a resting 12-lead ECG today as a baseline.
Fine by me. The last time I tried a treadmill test, I thought they'd need the crash cart.
Now, about the flank pain. Your CT on June 2nd is the right study to spot stones or gallbladder issues. We'll ask radiology to keep the slice thickness thin enough to catch small calculi. If something crops up sooner, worsening pain, fever, blood in urine, you call me or go to the emergency department. Moving to medications, aside from your inhalers and finasteride, you take aspirin only when the chest pressure comes.
Yes, a single 81 milligram chewable. I take ibuprofen once in a blue moon for joint aches, but I know that's not great for kidneys.
We'll factor that into the kidney follow-up. Your BPH seems stable on finasteride.
I'm up twice a night to pee, but I blame the gallons of water I drink trying to cure the dry mouth.
Hydration is good, though we'll try to ease the dryness. A heated humidifier chamber connected in line with your oxygen concentrator might help more than the bubble bottle. I'll have respiratory therapy show you options and get the distilled water delivered so you're not hunting for it yourself.
That would be a blessing. The hardware clerk knows me by name now.
Lastly, surgical history, stone removal, and a nasal mass excision 10 years back. Anything else ever put you in an operating room?
No, and I'd like to keep it that way.
Fair enough. Here's the plan we'll move forward with. Repeat full pulmonary function tests and see pulmonology right after. Schedule the nuclear stress test and do an ECG today. Confirm the June 2nd CT for your kidneys and set up a follow-up with me 2 months after all studies, or sooner if something urgent pops up. Does that cover your concerns?
That hits every target on the dartboard. Thank you, Julia. I feel heard.
You're welcome, Leo. We'll tackle this together. Before you go, let's walk down to the ECG room and I'll print out instructions for the sleep lab and humidifier. Any questions while we walk?
Just one. After all these tests, will I finally know why I can't breathe?
That's the goal. And once we know, we'll craft a treatment that lets you get back to those radios without running out of air.
Then let's get started.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Morning, Dr. Evans. Thanks for giving me an early slot. I know the schedule's always tight. I wanted to update you on the insulin you started me on last month and everything that's been going on since.
Good morning, Brandon. I'm glad you came in. Take your time and walk me through how things have been, starting wherever feels most important.
Okay, so first off, the insulin glargine, 15 units at night, has been a game changer. I used to see those terrifying numbers, 300, sometimes even over 400 on my meter, and just feel defeated. Now most of my readings are under 200. A few mornings I've even woken up in the 140s, which I haven't seen in years. I'm checking before breakfast and again before supper, like the pharmacist coached me. I haven't had any shakes or sweats or anything that makes me think I'm going low, so that's a relief.
That's wonderful progress. We'll dig into those numbers in a moment, but go on.
Right. The thing I noticed almost right away was my eyes. They've been blurry off and on for a while, but back when my sugars were sky high, it was this wave of fog. Now the blurriness is steadier, like a smudge on a windshield you can't wipe away. It worries me because my last proper eye exam was, summer 2021. I was supposed to wait until next year, but I'm thinking I shouldn't.
We'll absolutely move that appointment up. I've already sent a referral request, but we'll confirm dates before you leave.
Thank you. Another thing I've noticed is my energy. It's not back to college track team levels, but I can load groceries into the trunk without needing to sit down. And I'm not bolting out of bed 5 or 6 times a night to hit the bathroom. Maybe 2, sometimes 3 trips, which feels almost normal again.
That's a good sign that your kidneys and bladder are happier with the lower blood glucose. Tell me about sleep overall. Are you feeling rested in the morning?
More rested, yeah. Still have those orthopedic aches when the weather flips, but I'm not dragging myself through the day. Speaking of aches, my weight actually nudged up a bit, maybe a pound, 2 tops. It's small, but after months of the scale sliding backward, it feels reassuring. My appetite's steadier. I'm not forcing food anymore.
Glad to hear it. Any changes in the kinds of foods you're choosing?
I'm actually cooking again, less drive-through. Grilled chicken, brown rice, steamed veg. My girlfriend jokes I'm becoming a grown-up cook.
She sounds like a good influence.
She is. Now, something odd started about 2 weeks ago. It's not pain exactly, more like a flush, gentle pressure in the middle of my chest. It comes and goes, lasts maybe a minute. No racing heartbeat, no shortness of breath. I keep asking myself if I'm anxious, but it can happen when I'm just watching TV.
We'll unpack that carefully. Anything make it better or worse?
It just fades on its own. I haven't tried nitro or anything because I don't have any.
All right, we'll come back to it. Keep going.
Okay. My sinuses, oh boy. Every spring and fall I get stuffed up, but lately I've been waking with a concrete block in my nose and this low-grade headache behind the cheeks. Not much post-nasal drip, just pressure. Years ago, another doctor gave me Flonase and it helped, so when you sent that flunisolide spray by mail, I started it right away. 2 squirts each side morning and night, like the label says. It's only been a few days, so too early to judge.
Understood. We'll set expectations for that as well.
Finally, the hardware pain. Neck and left hip still grumble when it rains. I'm trying hard to stretch and to ration the Vicodin. Some weeks I don't need any, others I take 1 tablet at night so I can sleep.
I appreciate your mindfulness with the opioids. Anything else on your mind before I jump in?
Actually, yeah, the thyroid scan you ordered. Radiology called it a multinodular goiter. The biggest nodule is 1.7 centimeters, and they said my blood work looked normal. I'm not sure what to make of that.
Thank you for laying everything out so clearly. Let me recap to be sure I've caught each point. Then we'll tackle them one by one.
Sounds good.
First, your diabetes. Nightly glargine at 15 units, with home glucose now mostly below 200 and no hypoglycemia. Second, persistent blurry vision despite improved sugars, with your last eye exam in 2021. Third, overall energy better and nocturia down to 2 or 3 times nightly. Fourth, modest weight regain and improved appetite. Fifth, intermittent vague chest pressure without exertional symptoms. Sixth, recurrent nasal congestion and headaches, recently started on flunisolide. Seventh, chronic cervical and hip pain with decreasing but occasional Vicodin use. Eighth, ultrasound showing a multinodular thyroid and normal thyroid labs. Did I miss anything?
That covers it all.
Great. Let's start with the diabetes. Your numbers suggest the 15 units are helping, but we usually aim for fasting readings between 90 and 130 when it's safe. How close are your morning checks to that range?
Most are around 150. A couple were 142 or 145.
Excellent. I've enrolled you in the pharmacy diabetes program. Someone will call weekly. They'll review your logs and guide tiny insulin increases if needed. Meanwhile, keep testing twice a day and write down any lows or highs.
Will do.
About your eyes, I've asked ophthalmology to bring your diabetic retinal screening forward to next month rather than waiting until September. If they find any early damage, earlier treatment usually preserves vision.
I appreciate that.
Now, your improved energy and fewer bathroom trips are strong indicators that the lower glucose is easing stress on your kidneys. We'll still run an A1C and a basic metabolic panel today to quantify progress and ensure kidney function stays stable.
Okay.
Regarding the chest sensation, even though it doesn't sound classic for angina, I don't want to miss anything. I'd like to run an EKG in clinic today. If it's normal, but the feeling persists or worsens, we could arrange a stress test.
Fair enough. Better safe than sorry.
For your sinuses, flunisolide can take a full week or 2 to reduce mucosal swelling. Daily saline rinses can speed relief if you're comfortable with a squeeze bottle rinse.
I can try that.
As for the orthopedic pain, I'd like to refer you to physiotherapy to optimize joint mechanics and possibly decrease reliance on Vicodin further. If the weather flares remain severe, we can consider non-opioid options like topical NSAID gels or lidocaine patches.
I'd be open to that.
Turning to your thyroid, goiters are common and often benign, but nodules over 1 centimeter merit a closer look. I've already sent a referral to endocrinology. They may recommend a fine needle aspiration of the largest nodule.
Is that painful?
Most patients describe it as a brief pinch. It's done with local anesthetic, and you can go home right after.
All right.
Medication-wise, keep Vicodin strictly as needed, and note each dose on your glucose log so we can see if there's any correlation with BG spikes. Continue flunisolide twice daily for at least 10 days before judging efficacy. Maintain glargine 15 units nightly, but be ready to adjust in 2-unit steps with pharmacy guidance.
Got it.
I'll order the labs, the EKG, and the physiotherapy referral today. You'll get a call within a week for the diabetes check-in, and I'd like you to phone my office in exactly 7 days with your average fasting glucose and any insulin changes. Does that timeline feel manageable?
Yes, that works. I appreciate how thorough you are.
You're doing the hard work, Brandon. I'm proud of the changes you've made. Before you go, any worries we haven't addressed?
Just hoping the chest thing stays mild, but you've given me a clear plan.
Excellent. After the test today, my nurse will bring in paperwork and show you how to reach the on-call line if anything urgent crops up. Take care of yourself, keep walking when you can, and enjoy cooking those grown-up meals.
Thanks, Dr. Evans. See you or talk to you next week.
Looking forward to it. Take care.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Morning, Claire. Have you got 5 minutes? The main steam sterilizer on Theater 3 went down overnight and we're already 70 sets short for today's orthopedics list.
I heard the alarm at 5:30. Biomed says the heat exchanger failed. Earliest fix is tomorrow. I've rerouted the knee scopes to the day surgery autoclave, but that only buys us 18 trays.
That leaves us 29 primary hips with no clean instruments. I've rung St. George's to see if they'll loan us surplus sets, but their trauma board is packed after that M25 pileup.
Could we convert the afternoon slots to arthroscopy and bump the joint replacements to Saturday? The patients are pre-op cleared, but we'll need anesthetics to cover weekend overtime.
Finance will scream, but delaying an elective is cheaper than a cancellation on the table. I'll draft a risk note for the medical director. Can you update the surgeons before their 8 o'clock huddle?
On it. I'll also email infection control. Cross-site loan kits need an emergency sterility audit, and we'll have to warn wards about extended fasting time so patients aren't left hungry for nothing.
Thanks. Let's aim for a final plan by 9. If Biomed surprises us and the part arrives early, we can pivot back. But I'd rather over-communicate than spring chaos on the scrub teams.
Agreed. I'll loop in dietetics and patient transport. With luck, this is just a long day, not a national scandal.
Now look at question 26.
Hey, Dr. Nguyen, you free to talk about the new AI sepsis alert? IT wants to push it live across the ED tomorrow, but the nurses are already drowning in pop-ups.
I saw the demo. The algorithm flagged 8 false positives in a 2-hour sandbox, mostly COPD exacerbations. If we roll it out as is, the alarm fatigue will torpedo uptake.
Exactly. The vendor's rep swears sensitivity trumps specificity because someone will check anyway, but we both know unchecked alerts end up muted. I'd rather miss a bell than train staff to ignore all of them.
We could gate it behind a lactate of 2 or a systolic drop of 30. That trims noise without losing the genuinely septic. We'd need analytics to verify before flipping the switch, though.
IT says they can hot patch the threshold if we give them parameters today. Can you pull last quarter's ED admissions and run a retrospective? Even a 30-patient sample would strengthen our case.
Sure, but ethics needs to sign off on secondary data use. I'll file an expedited review, should clear by lunch. If we get preliminary stats by 4, we can argue for a 1-week pilot instead of system-wide chaos.
Perfect. I'll brief triage leads so they don't feel blindsided. Also, pharmacy wants in because the alert auto-suggests a sepsis bundle that includes meropenem and stock's tight since the recall.
Meropenem. That's overkill for half our population. We'll tweak the order set to ceftriaxone plus if no hospital-acquired risk, better antimicrobial stewardship, and fewer formulary headaches.
Love it. Let's meet at 3 with the data and a pared-down bundle. If administration balks, we'll remind them the Joint Commission dinged us last year for alarm fatigue, and no one wants a repeat citation.
Deal. I'll crunch the numbers. See you at 3, hopefully with a graph that keeps the red ink out of tomorrow's rollout.
Now look at question 27.
Morning, Amina. Have you seen the new telehealth ruling from the college? They're insisting any video consult for patients across provincial lines now requires dual licensure, even if the patient's just at their cottage in Quebec for the weekend.
I read the memo at 6. That torpedoes half our virtual COPD reviews. Half those retirees are snowbirds or lake hoppers. Legal says we either cancel next week's clinics or find an interim workaround.
Canceling isn't an option. I've got oxygen titrations pending. What if we rebook them as telephone follow-ups? The regulation only targets synchronous video, not audio only, at least until July.
Technically true, but respiratory therapy needs the pulse ox readings we capture on camera. We could ship loaner Bluetooth oximeters, but logistics can't get devices to Gatineau and back in 3 days.
Could we partner with a local CLSC to run vitals and beam them back? It would count as an in-person allied health visit, and we'd still satisfy the new standard.
Possibly, but Quebec billing codes differ, and our EMR doesn't speak RAMQ. IT would need to spin up an HL7 bridge by Friday, and they're knee-deep in the EMR upgrade.
All right, Plan B. I apply for a Quebec license under the Emergency Expedited Clause. You triage which patients genuinely need video versus those we can manage by phone. I can probably cover the critical 6 by next Wednesday.
Do it. I'll draft a consent addendum explaining the jurisdictional handoff, so patients know whose college to complain to if something goes sideways. We'll revisit once the Federation sorts out a national approach.
Deal. I'll start the paperwork now. If immigration ever processed my permanent residency, this would be easier. Anyway, thanks for the rapid triage. Let's huddle again at 4 in case the college fires off another surprise.
Sounds good. If they do, I'm charging them for coffee pods.
Now look at question 28.
Siobhan, have you got a moment? The ransomware incident has knocked out our PACS viewer again, and radiology can't access last month's CT angiograms. Vascular rounds start in 45 minutes. I just left the war room. CyberSec isolated the rogue server, but the fallback node in Cork hasn't received the Delta backups since Thursday. We're missing 4 days of imaging. That's fatal for the AAA surveillance list. Mr. O'Mahony's sac diameter could have jumped a centimeter over the weekend, and we'd be flying blind. I've asked GE to push the raw DICOMs directly from the scanner console to a secure laptop. It's clunky, but we can project on a standalone screen in the MDT room, air-gapped from the network. Good stopgap, but endovascular still needs 3D recon for graph sizing. Their planning software lives behind the firewalled server farm that's currently quarantined. We can boot an offline instance on a spare workstation. I've already retrieved an old installer. IT approved a temporary exemption as long as we keep the machine off Wi-Fi and document everything for the data commission. Brilliant. I'll brief the consultants to expect single-use USB transfers and no live RIS queries. Also, pharmacies worried about contrast shortages. Belfast just diverted 100 vials our way, but they arrive after noon. I'll reprioritize the list. Emergent ruptures first, elective EVARs rescheduled. Anesthetics is fine with shifting the GA slot to tomorrow if we give them heads up by 9. Perfect. I'll update the theater board and placate scheduling. CyberSec wants a written workflow to prove we maintain continuity of care. Can you document the DICOM bypass and offline recon in plain English? Already drafting. I'll have it signed before lunch, so we're covered if the HSE audits. Let's pray the decrypt key arrives before this turns into WannaCry 2.0.
Now look at question 29.
Lucy, the National Supply Center just flagged a critical shortage of O-negative units. Only 18 bags left for the whole Southwest region. Tomorrow's transplant list still has 2 pediatric livers booked.
I saw the alert pop up in PathNet. If we cancel those, the grafts expire and the donor chain collapses. Could we run the kids on cell salvage alone and reserve the O-neg for unpredicted bleeds?
Cell salvage covers about 40% of anticipated loss, best case. Anesthetics won't sign off unless we have 4 units in the fridge per child. I'm thinking of converting Theater 4 into an O-positive zone with RHIG back cover, but that's off protocol for under 8s.
And ethics will melt. What about tapping the military stockpile at Salisbury? Mod policy says they can release emergency reserves for civilian paids if we get a Defense Medical Services consultant to co-sign.
I've already rung their duty officer. They can courier 6 units by 05 if NHSBT signs the indemnity. Could you draft the justification letter? It needs transplant surgeon, hematology, and executive signatures before midnight.
On it. I'll also task the BloodTrack software to reroute any unmatched O-neg from peripheral trusts straight here. That buys us a buffer if Salisbury hits traffic on the M4.
Brilliant. I'll brief PICU charge nurses about the contingency RHIG pathway and prep the parents in case consent wording changes. Let's reconvene at 22:30 to confirm the courier's wheels are rolling.
Deal. If this works, we save 2 kids and dodge a national headline. If it doesn't, at At least we didn't wait for the last bag to vanish.
Now look at question 30.
Grace, have you felt the humidity in Theater B? Since Estates switched to the new carbon-cutting ake cycle, my lens keeps fogging mid-laparoscopy.
Tell me about it. The green target protocol drops airflow 10% every half hour to save energy. Great for CO2 metrics, terrible for endoscopic visibility and sterility thresholds.
Last night I measured 68% relative humidity. ISO 14664-4 lets us max at 60. If a joint gets infected, no amount of carbon offset will cover the litigation.
I've escalated to facilities, but they're proud of hitting their net zero milestone. They offer defog spray for the optics as if that fixes airborne bioburden.
We need hard data. Could you deploy continuous particle counters for a 24-hour run and overlay that with the HVAC cycling schedule? If we show spikes when the dampers throttle, we'll have leverage.
Already placed the sensors and set up a live dashboard. Early read shows particle counts triple during low flow intervals. I can export graphs for tomorrow's governance meeting.
Perfect. Meanwhile, I'll request a clinical exemption so Theater B reverts to full flow until a proper solution, maybe a variable speed compressor that maintains positive pressure while still trimming CO2.
Finance will argue about the capital cost, but infection control will back us. I'll also flag supply chain. Endoscopic gear warranties don't cover moisture damage. We've lost 3 scopes this month.
Good catch. Let's combine the scope repair invoices with your particle data. Money talks louder than CFUs. Meet me at 7:45 outside the boardroom.
See you then. If they still resist, I'm bringing a fogged-up camera head as show and tell. Nothing like visual proof to clear the air.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Good afternoon, Dr. Reynolds. I'm thrilled you could join us today from Boston to talk about one of the hottest frontiers in medicine, CRISPR-based gene editing for sickle cell disease.
Thanks for having me, James. It's a privilege to discuss a therapy that's moved from bench to bedside faster than many of us dared hope.
Before we dive into the science, could you outline in broad strokes what makes CRISPR-Cas9 editing different from earlier gene addition approaches we tried back in the lentiviral days?
Certainly, traditional lentiviral vectors insert a correct copy gene into hematopoietic stem cells, but integration sites vary and expression can be unpredictable. CRISPR, by contrast, cuts at a pre-specified genomic sequence, in our case, the erythroid enhancer of BCL11A. Disrupting that repressor reactivates fetal hemoglobin, which sidesteps sickling entirely because HbF doesn't polymerize under hypoxia.
That enhancer knockout strategy, often called the BCL11A edit, was front-page news after the New England Journal of Medicine piece in December 2023. Yet lab success doesn't always translate clinically. How has it fared in practice?
Remarkably well. The NEJM cohort showed 97% freedom from vaso-occlusive crises at 18 months, but I think the more compelling evidence is individual stories. Take our patient, Ms. Tremaine Johnson, a 28-year-old from rural Georgia.
I'm all ears. Walk us through her journey.
Ms. Johnson had genotype HBSS with monthly crises requiring morphine PCA. Hydroxyurea gave her maybe a 20% reduction, but she remained transfusion dependent. In January 2024, she enrolled in our Phase 2 trial. We harvested autologous CD34+ cells via Plerixa for mobilization, edited ex vivo with Cas9 RNPs targeting the BCL11A enhancer, and myeloablated with busulfan before reinfusion.
Sounds intensive. Any peri-transplant complications?
She developed transient mucositis, grade 2, and febrile neutropenia for 48 hours, standard for busulfan, managed with cefepime and growth factor support. Neutrophil engraftment occurred on day 12, platelet on day 18.
And clinically afterwards?
By month 3, her HbF hit 44%, total hemoglobin 12.3 Grau/Prüller. She hasn't had a vaso-occlusive episode in 16 months, no transfusions, and her 6-minute walk distance improved from 280 meters to 470 meters.
Those numbers are dramatic. Critics, though, flag durability. Will the edit remain stable for decades? What's your view?
Thus far, vector copy number assays show stable indel rates in long-term multipotent progenitors out to 36 months in our earliest patients. But yes, we need decade-long surveillance, something the FDA mandated in the post-market commitment program.
Speaking of oversight, the therapy recently earned an FDA BLA priority review, yet cost projections hover near $2 million. How do we square such price tags with equitable access?
That's the ethical crux. Manufacturing costs will likely fall as automated closed-system editing scales. Meanwhile, value-based agreements, where payers reimburse over time contingent on durability, are gaining traction. Medicaid in California is already piloting one.
Pivoting slightly, there's buzz about base editing platforms that skip double-strand breaks entirely. Are you involved in those trials?
We are gearing up for one. Instead of knocking out BCL11A, we're using an adenine base editor to directly convert the pathogenic GTG codon to GAG, turning sickle hemoglobin into harmless HbA. Preclinical off-target profiling looks clean, but until we prove safety in humans, the nuclease edit remains our standard.
Interesting. Let's circle back to Ms. Johnson. Psychosocially, how has life changed for her?
She moved from part-time employment to full-time teaching. The biggest shift, she reports, is freedom from constant pain anticipation. During her last clinic visit, she said, "I finally committed to a 5-year mortgage because I'm no longer planning my life around hospital admissions."
Powerful testament. Yet you mentioned busulfan. Aren't we trading one morbidity for another, given its gonadotoxicity?
A valid point. We counsel fertility preservation preconditioning. Fortunately, emerging non-myeloablative antibody drug conjugate conditioning, like CD17-TAN-ADC, might eliminate chemotherapy entirely within 5 years.
Regulators aside, are community hematologists ready? Editing requires GMP suites, apheresis logistics, and specialized follow-up.
Capacity is limited. One creative solution comes from a Cleveland consortium retrofitting idle COVID-era bioprocessing pods as regional cell therapy hubs linked to rural feeder clinics. Think of it as a hub-and-spoke model for genomic medicine.
Let's zoom out to disparities. Sickle cell predominantly affects African descent populations historically underserved by research. Has trial recruitment reflected that?
Yes, 61% of enrollees thus far self-identify as Black or African American, thanks to deliberate community engagement partnerships with churches and HBCUs. Trust building is essential after the legacy of Tuskegee.
Any surprises from long-term labs? Clonal hematopoiesis, cytopenias.
We screen with error-corrected sequencing every 6 months. So far, no clonal dominance or myelodysplasia signals. That said, vigilance is critical, especially because Cas9 introduces p53-mediated DNA damage responses.
Final few questions. What's the single biggest technical hurdle still in your sights?
Efficient in vivo editing to obviate stem cell harvest altogether. Lipid nanoparticle delivery to marrow is tricky. Off-target hepatic uptake remains high, but the first primate data published in Nature Medicine last month are encouraging.
And ethically, what keeps you up at night?
Germline creep. Even though we're squarely in somatic territory, public fears conflate the two. Transparent communication is paramount so we don't jeopardize legitimate therapies through societal backlash.
Dr. Reynolds, this has been a masterclass in both science and humanity. Any closing thoughts for clinicians listening who treat sickle cell in the trenches?
Stay abreast of trial eligibility criteria. Referrals at the right time matter. And remind patients that curative options are no longer hypothetical. They're happening now, one edited cell at a time.
Thank you again for sharing your expertise and Ms. Johnson's inspiring story. We'll be watching the field closely.
My pleasure, James. Conversations like this help translate breakthroughs into real-world impact.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Thank you for that generous introduction. I'm Dr. Aaron Blake, an infectious diseases physician and clinical microbiome researcher at King's College Hospital in London. And today I want to take you on a journey that starts deep inside the human gut and ends, perhaps surprisingly, at the front lines of cardiometabolic medicine. Over the last decade, you've heard scattered headlines about the microbiome, vague promises that bacteria could treat everything from eczema to depression. What I want to share is the story of how those promises are crystallizing into rigorous science, why our traditional reductionist view of single pathogens is giving way to an ecological perspective, and how one patient named Trevor changed the way my team and I approach metabolic disease. Let's wind the clock back to 2019, just before the pandemic turned our laboratories into emergency PCR factories. A multi-center Dutch trial had published an elegantly simple but provocative result. Transplanting stool from lean donors into adults with insulin-resistant obesity produced a transient but significant improvement in peripheral insulin sensitivity. The effect faded by week 18, and critics called it a microbiological honeymoon, yet something about the signal was unmistakable. There was a dial we could turn, changing the microbial conversation inside the intestine, and the host's metabolism listened. At the time, my group was studying Clostridioides difficile recurrence, so fecal microbiota transplantation, or FMT, was firmly within our technical wheelhouse. The question was whether we could move FMT beyond rescue therapy for refractory C. difficile, and pilot it as an adjunct for metabolic syndrome in the National Health Service. Enter Trevor. He was a 52-year-old bus driver from Brixton with a body mass index of 37, hemoglobin A1C of 8.4%, and a blood pressure reading that brought our triage nurse to a sharp pause. He'd tried metformin, tolerated it poorly, had declined GLP-1 agonists because of needle aversion, and was now facing an unwelcome conversation about bariatric surgery. Trevor's medical notes described him as non-compliant, a word I've come to loathe, because it blames the patient for an ecosystem of social and biological forces. Trevor's shifts alternated weekly, 5 a.m. starts one fortnight, midnight finishes the next, and he stole meals from petrol station shelves at irregular hours. He wasn't ignoring advice. He was pinned beneath a schedule that dismantled every circadian and dietary rhythm we asked him to honor. We enrolled Trevor in a first-in-human pilot approved by the UK Medicines and Healthcare Products Regulatory Agency, combining dietitian-guided fiber preloading with a single FMT delivered via lyophilized capsules. The stool donors were rigorously screened university athletes with low visceral fat and a Shannon diversity index that read like botanical gardens for microbes. Trevor swallowed 30 capsules under observation, grimaced at the taste of glycerol, and then went home prepared for nothing more dramatic than nausea. For the first 2 weeks, that's exactly how the story unfolded. Some bloating, a bit of flatulence, daily calls from our study nurse, and not much else. Week 3 is where things became interesting. Trevor's continuous glucose monitor, yes, we fitted him with one despite his needle anxiety, started drawing curves that looked less like Himalayan peaks and more like gentle Welsh hills. Postprandial excursions halved. He reported, almost sheepishly, that he felt lighter, though his weight hadn't yet budged. By week 6, his fasting glucose had fallen from 9.8 millimol per liter to 7.1, and his systolic blood pressure dropped by 12 millimeters of mercury, despite no change in ACE inhibitor dosing. If this were an isolated anecdote, you'd be right to raise an eyebrow. But Trevor was patient number 7 in a cohort of 10, and 6 others showed the same metabolic ripple. When we sequenced Trevor's stool, the before and after plots were almost cinematic. The relative abundance of Akkermansia mucinifila, a mucin layer grazer associated with improved barrier integrity, jumped from 0.2% to 4.7%. Short-chain fatty acid producers like Faecalibacterium prausnitzii and Roseburia hominis flourished. More intriguingly, bile acid metabolizing clusters shifted, converting primary bile acids into secondary species that activate the TGR5 receptor, a molecular switch known to enhance energy expenditure in brown adipose tissue. In plain English, Trevor's gut became a bioreactor fermenting dietary fiber into hormonal signals that told his liver, muscle, and fat how to behave. Of course, any TED-style revelation needs scholarly ballast. Last year, the American Journal of Clinical Nutrition published a meta-analysis pooling 17 FMT trials targeting metabolic outcomes. The aggregate drop in HOMA-IR stood at 19%, modest but clinically meaningful, especially when coupled with lifestyle coaching. Another Lancet Microbes study in April 2025, fresh off the press, reported that responders share a common baseline trait, an underrepresentation of genes encoding butyrate synthesis, suggesting a niche vacancy that donor microbes can exploit. I can already hear the cautionary whispers. FMT isn't a panacea. It carries risks of transmitting undetected pathogens or antibiotic-resistant genes. The FDA's safety alert in 2022 reminding us of 2 immunocompromised patients who acquired extended-spectrum beta-lactamase E. coli post-FMT still echoes in ethics boards worldwide. That's why my lab is pivoting toward next-generation approaches, defined consortia of cultured microbes, administered with the precision of a biologic drug rather than the bluntness of blended stool. Think of it as moving from blood transfusion to synthesized recombinant clotting factor. Trevor's story, though, taught me something textbooks can't. On his 3-month follow-up, he walked into clinic 6 kilograms lighter, not because the microbes burned calories like a metabolic furnace, but because success begets motivation. Stable glucose curves allowed him to sleep without nocturnal polyuria. Better sleep drove morning energy. Energy begot a 30-minute walk around Brockwell Park that became a habit. Behavioral economics calls this positive feedback loop a virtuous circle, and sometimes biology needs to give psychology a head start. So where does that leave us? I believe we are witnessing the early days of ecological therapeutics. Within 5 years, I expect we'll see regulatory microbial cocktails licensed for non-communicable diseases, manufactured in stainless steel fermenters and prescribed alongside statins and antihypertensives. The NHS has already commissioned a cost-effectiveness analysis, and early modeling suggests a £7,000 quality-adjusted life-year threshold, well within NICE approval territory, if we can keep production costs below £800 per course. As I conclude, I want to circle back to Trevor, because statistics seldom inspire, but stories do. At his last visit, he handed me a laminated Dayrider bus ticket. "That's the last shift I drove before the study," he said. "I keep it to remind myself that sometimes the route changes, but you still arrive." Trevor's gut took a detour, and in doing so, he changed lanes in the trajectory of his health. Our task now is to make that detour a well-lit motorway for millions more. Thank you for listening, and I look forward to the day when prescribing a healthy microbiome is as routine as recommending a Mediterranean diet. Until then, keep asking the awkward questions, keep challenging the dogma of single-target pharmacology, and remember that inside every patient is an unseen universe waiting to be cultivated.